Good morning. We're going to get started.
Good morning, everyone. Thank you very much for being here, day 2 of our wonderful conference. My name is Marcelo Bravo.
My name is Leanna Garraway.
And we will be your MCs throughout the rest of the conference. Welcome to the 2023 Northern BC Research and Quality Conference, Looking to the Future, Health in the North, a joint initiative organized by UNBC Health Research Institute and Northern Health.
Now it is our great pleasure to introduce the UNBC Chancellor, Elder McIntosh, to provide a morning welcome for it to us.
Howdy. I like that. Well, for those who don't know what I said to you, I said hello, and you said hello back to me. Or I would say Bandada Hunzu, good morning. And that's Decal carrier word. So we have an excited group of people here. Just can't wait to learn a lot in the presentations that will happen today. So that's great. And of course, it's very positive that we come together to collaborate, build relationships, and talk about what's really important in the North. You know, a lot of times we get forgetting in the whole realm of things. And when we have people that come together as you to support what's happening in the North, that's a fantastic thing. So I'll get you to all stand, please. So I want you to take a nice deep cleansing breath throughout your whole body. Breathe deep, pull that clean air into your body to awaken every cell. And just think about all the cells that are sleeping in your body. We want balance and harmony, so we awaken them all. And if you can imagine breathing into your body, and then it connects with a cell, and it's been dormant. And then all of a sudden it pops with light. And then you hear pop, 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 as all these cells are being awakened in your body. We need our body to work in unison with our mind. And we need to consider our body, how important it is. It's our vessel, it's our temple. And are you looking after it? Are you looking after your body? We are physical, mental, emotional, spiritual. And even though we're in an academic setting, which means that you're in your mind, we need to collaborate with all the other levels of who we are to bring them all together, because we can't negate one. We negate one, we're not whole. So as we breathe into our body, just think about yourself outside and it's beautiful. Coming winter morning, crispy out there. You stand on the beautiful earth, Mother Earth, and you take that breath into your body and you pull it all the way down into your feet. You feel your feet sink into the deep, rich soil of Mother Earth. You can smell the richness of her soil. You can feel it between your toes. And there she grounds you into today, into this very moment. We come through the doors as individuals, but when we come together as we are today, we create that sacred energy, that sacred circle. So then we become one. We are no different. And we're here to support whatever is talked about within the conference. So just remember throughout the day, remember your breath, take it in, awaken yourself, and we continue our journey on this beautiful earth plane. Over 9,000 years, as supported by lithic evidence, the Claytley people lived with an ancient belief. We, the people of the mighty Fraser and the Chaco rivers, believed in our innate responsibilities was to protect our waters. For the salmon who made their way up to their spawning grounds, giving up their lives for the birthing of the new. The salmon provided food for our people, food for the wildlife. The salmon also provided food for the forest. Chunto Wadajat, the only inland rainforest in the world, which is under our protection, also provides lithic evidence of the salmon's DNA in the great cedars. Over 9,000 years of memory of the Clightly people who lived in harmony with Mother Earth. We now invite our guests who have come to our unceded ancestral territories to now honor our people. Our remembrance of our gift to you. Let us together live in harmony, work with respect for each other, and play as we come together on our beautiful lands. Our ancestors have always welcomed people to our territories. On behalf of Clightly Tenase elders, our youth, community members, and chief and council, it is absolutely my honor to welcome each and every one of you to our traditional territories. All my relations must see. Thank you. Please be seated.
Thank you so much, Elder McIntosh.
Now, it is our pleasure to invite Dr. Fraser Bell, Northern Health Vice President, Planning, Quality, and Information Management, and Dr. Paula Wood Adams, UNBC's VP Research and Innovation, for a welcome message.
Great, thanks very much, Marcelo. I'm still getting used to that Dr. Fraser Bell thing. Thank you, Elder McIntosh, for the opening. Very, very wise and inspiring as always. So thanks for having me here. I just do want to start with a welcome to everyone here. It's great to see the group. It's interesting how you sort of a lot of empty seats until the last minute, and then it fills up. And so it's great to see the attendance that we have today. And I hope everybody enjoys the workshops that proceed and the talks. So today, just as a quick opener, I did want to just make a couple comments, and I really wanted to focus in on partnership. And probably yesterday afternoon, I did a talk about the memorandum of understanding between Northern Health and UNBC, and whoever attended yesterday is going, oh my gosh, great. Another 15-minute talk about the memorandum of understanding. But I do think, I will stop and I will say, we do need to recognize that. We have something incredibly special here between our two organizations. The ability that we've been able to work together at an organization to organization level is absolutely phenomenal. It's fairly unusual, and we've achieved some great things. So we do need to stop and reflect the work that we've been able to do together, and the work that the partnership that we've been able to achieve with other organizations based on the platform that we've created. So that's really important. But that is not what I meant to talk about around partnership. The other partnership I wanted to flag today is in the name of the conference, and it is the Northern BC Research and Quality Conference. And I think that's another partnership that I think we really need to celebrate, because it's unique too. I think when we started doing these, and we've done a lot of these conferences now together, and it's, I think, absolutely phenomenal. And I think it speaks to the uniqueness, again, of the North and of our relationship, because it's a research and quality conference. It's not a research conference. It's not a quality conference. It's a research and quality conference. And I think that is incredibly meaningful. And it was meaningful to the people when we started doing it this way. We wanted to recognize that when we come together as a relatively close knit group, relatively smallish in global perspective, we have a lot of opportunities based on the alignment of what we can do together, not just our separate strengths. And so the idea of bringing research and quality together to talk about where there are alignments, opportunities, the synergies that we can create between the two. And a lot of people would not talk about a knowledge translation cycle, the fact that you know, the quality improvement people are always pulling people together, service providers, to say, how can we improve? What's the first step they do? They look at the evidence to say, what does the evidence say we could do to improve? And they work to implement that. Well, where does the evidence come from? It comes from research. But on that journey, especially in a unique jurisdiction like ours, the northern rural Indigenous communities, we often identify questions that we can't answer. So there's the opportunity for new research and creation of new knowledge. So a huge cycle that we can and do work on together on a regular basis. But I guess you might wonder then, why didn't we call it a knowledge translation conference? And I think that's meaningful too, because I think they're different. I think researchers, they work in different places, they do different things than quality improvement people. But I think we do need to recognize the strength of the separateness of those two skill sets, but also the alignment and synergies that they bring together. And so to me, this conference is a reflection of that, and I'm excited to be part of the kickoff for the day. So thank you very much. And I am also happy to introduce Dr. Paula Wood-Adams, Vice President of Research at UNBC.
Thank you so much. It's a real pleasure to be here this morning. And one of the things that I have to say is every time I hear our chancellor speak at the beginning of one of these events, is I always find my breath taken away at her generosity in welcoming us to the historical lands, unceded lands of the Claydley Tenay people. I just cannot believe how generous and welcome she and her people are. So I'm really happy to be working here. Many of you know I just arrived a couple of months ago. And one of the reasons I came here was because of the amazing researchers that I met when I came for my interview. I met them on the hiring committee and in my public presentation, and the things that I read online as well. And I realized that this was a special place. And I feel that even more now after 2 months. And one of the things that I never thought I would have the opportunity to do was actually to contribute to the state of healthcare in the North. Even though I knew there was medical and health researchers here, I didn't know that I would be able to be involved. And that is also a real honor. And it's such important work that you're doing. And this conference is really showing how much you believe in that work and how much effort you're putting into creating new knowledge, training the next generation, passing the knowledge to the practitioners, and ensuring that that the way that they work is actually the best possible way that they can. So all that to say, thank you. I am so happy to be here. And I really also want to welcome those who come from Northern Health and elsewhere to our campus, which is lovely. It's cold right now, so it's not quite as lovely as in the summertime, but it is a beautiful campus. And I'm really happy to welcome you here. I do want to mention that MOU. I'm not going to go into detail because I understand that that's already happened. But I do want to say that it is a very important partnership because it allows for collaborations. It allows for events like this. It also provides some funding that our researchers can then use to leverage with other sources of funding. And that is kind of a very positive cycle that produces opportunity for everybody that is here today, and all of our students. So I'd just like to close by wishing you all a productive and enjoyable conference, and once again thanking you for inviting me. Thanks.
Thank you again, Dr. Fraser-Bell and Paula Wood-Adams for these remarks. Before we continue with our exciting program today, we would like to provide some acknowledgements and thank yous.
So this conference couldn't have happened without a lot of help from people. So we want to thank the Conference Advisory Committee, the Planning Committee, the Person and Family Engagement Committee, everyone who helped us review abstracts, and all of the volunteers that are helping us out today. We also want to acknowledge the financial support for this conference from Northern Health and UNBC. And we also received financial support from the Provincial Health Services Authority and the BC Support Unit. And also a huge thank you to UNBC Services, who are managed to put this on so well, catering, IT, the bookstore, which is offering 25% off for conference attendees these 3 days, and the President's Executive Council for supporting the room rentals. And
for everyone for being here.
Oh, sorry, and Barry at Coffee Services.
Now is the time to introduce our conference keynote speaker, Dr. Sheila Blackstock. Dr. Sheila Blackstock is a distant nursing scholar and an associate professor at the University of Northern British Columbia. She has over 34 years of nursing experience, ranging from acute care to rural health, Indigenous and occupational health nursing. Her career aspirations on graduating were to teach nursing and to give back to the northern communities where she trained and worked. She completed her doctoral studies and continues to teach nursing and is active in research and scholarship. Throughout her career, she develops and sustains partnerships with Indigenous leaders and communities to create innovative theory and nursing practice courses. Her research and scholarship focus on improving Indigenous holistic health and the empowerment of nurses and nurses leaders to improve the quality of nursing practice work environments.
So Sheila's graduate work and doctoral dissertation focused on negative workplace behaviors and bullying and incivility experiences of nurses and new graduate nurses. She uses an organizational context to explore the role of oppression embodied within organizational workplace structures, processes, and policies. Dr. Blackstock's research is currently exploring the intersections of racialized incivility and incivility experiences of nurses in various practice contexts. And her aim for the talk today is to explore the role of structural empowerment, nursing leadership, and self-determination in improving working conditions and addressing incivility and racialized incivility experiences in various practice settings. Please join us to welcome Dr. Sheila Blackstock. Really quick change of PowerPoint here. I just need to share screen. I'm sorry, Sheila. Bree, are you seeing it online? Okay. Are you seeing, you're still seeing it online? Okay, thank you. Thank you.
Thank you so much for that warm introduction. And I'd like to extend my sincere gratitude to Elder McIntosh for opening us up in such a good way on this day. This day when we're reflecting the services of Indigenous veterans. And so I'd like to respectfully acknowledge their service as well. And my gratitude to the organizing committee and to the of the importance of this conference, the colleagues and students and community members that are here in this room and those joining us online. I'm a Gitxsan scholar and a proud visitor to the unceded traditional territory of the Lheidli First Nations. For those of you joining online, please extend and express what lands you're joining us from today. The next picture is a picture of fires. And this is really, I've been taught by my elders as I'm learning my language in the Gitxsan territory. It really, as individuals, when we come from different fires, it reflects our respective culture, our tradition, our practices. And so today, when we come together, we are gathering around a common fire. And so this is a space where we talk about some important topics, which you've already done in terms of the pre-workshop events for this conference, and which will continue on through this important next day's events in terms of workshops and presentations. For this presentation, we're going to reflect on decolonizing health. That's a big topic. And leading the future of health in the North, because it's all related. So decolonizing health. I'm trying to use my technology here, but it's not working. I'll use another way then.
I'm sorry.
That's okay.
It did work when we tested it.
Yeah, there we go. Oh. Okay, there we go. And so just a bit of an overview of today's presentation. I'll start off with a formal introduction in a moment. I'll talk about the structural and social determinants of health, but I also wanted to reflect on the role and the importance of partnerships, as I've mentioned before, in terms of those partnerships with communities as it relates to scholarship as well. So not just research, but also scholarship and the quality of those relationships. And the fact that it's going to be nation-based, community-driven curriculum development and empowering the organizational change in nursing leadership, and finally ending off with finding a way forward on this journey. I'll share with you experiences of working in partnerships with Indigenous peoples and students and communities. We never go anywhere without our students as academic, nor should we. To give a sense of how we can do this work together. I'll try it. There we go. So, Hadi Amasa, Unalakan, Anas Hadi Sisinkwik. I am a Gitxsan and I am European on my mother's side, thus the red hair. I am from the Wilkes-Gill clan, and my traditional name means one who takes care of others or treats the sick. I'm from Northern BC and so proud to be at this forum today. I've grown up on forestry ranger stations, and that may be a bit of a new term for some of you in the room. I've been fortunate to live in rural northern communities, beautiful towns, enjoying fishing, hunting, berry picking, being by the water. And if you know me, you know that being outside brings me great happiness. In this presentation, I have pictures of communities, students, and practice environments as I've lived and worked in. It reflects my journey and interconnections, the strengths of connections to northern rural communities, because it's unique, isn't it? And it really reflects the character and traits of community members' northern ways of being. Looking after one another for the betterment of the community, these connections as Indigenous peoples give us strengths. In this picture, you see me fishing, although I don't know if the Fish and Wildlife Officer would say those are appropriate size of fish, but I think they're, so don't, so that's my brother, my older brother, Michael, and my sister, Cindy, and we are all proud alumni of UNBC. And those are, yeah. And this is pictures of up north at a cabin. And this is a picture of a journey I took with Tecumseh when I was asked to develop a course. I spent a day and a half on the river with elders and students and youth. And I'll talk about that in a minute. So these journeys hold personal meaning to me as an academic, but also as a reflection of my personal ways of knowing. Again, growing up and living in northern landscapes. When you're situated and living in northern rural BC, the wild landscapes are beautiful. The terrains paint a canvas of calming presence, yet it brings with it many diverse challenges. Limited access to health and social services, supports, resources, and a lack of culturally appropriate services. And the need to establish strong local food systems are just a few of the obstacles to achieving better health outcomes. in communities, and these are further multiplied in Indigenous communities. Nationally, there's a connection between First Nations, Métis, and Inuit peoples through our land, our waterways, our skies, and the Creator. We also share the impacts of the colonial systems and the role of oppression. The next picture may be triggering for those of you in the room and those of you online. The residential school program was created, as we know, to assimilate Indigenous children into settler culture and often involve forcibly removing children from their communities, with the overall goal of eliminating Indigenous peoples in Canada as distinct peoples. Indigenous peoples in Canada face substantial socioeconomic inequalities compared to non-Indigenous peoples due to the impacts of colonization, such as the forced removal from their lands, enduring the impacts of global warming, and recently receiving inequitable health services amidst COVID-19, despite good efforts. Amongst all these vectors assaulting Indigenous peoples, one wonders then, what are the origins of Indigenous health? And how does it compare to the contemporary conceptualization of Indigenous health? Historically, the conceptualization of Indigenous health was treated as a holistic phenomenon, encompassing physical, emotional, mental, spiritual, and environmental aspects. Health was connected to all aspects of our lives, to our cultural identity, the community governance, to housing, water, cultivation, and storage of food systems, and traditional medicine was applied across the lifespan of Indigenous people. We work together for the sustainability of our community and other nations in partnership. There was an understanding of the ways of being and knowing in cultural practices. And again, the practice of traditional practices of food cultivation, medicines, etc. The contemporary conceptualization really reflects the effects of colonization that continues today through funding and legislative structures that really deconstruct this holistic phenomenon of Indigenous health into separate entities. For example, Indigenous health is delivered through provincial health, territorial, and federal bodies and systems, different structures for housing, education, and social work, and the list goes on. This ongoing marginalization has resulted in limited access to culturally appropriate and relevant health services, resulting in grave health outcomes, morbidity, mortality, and high rates of Indigenous people. So it's important then to take a pulse check. What is the current status of Indigenous people today and the associated systems and processes? Currently, Indigenous people face systemic issues, including racism, discrimination, and bias within institutions, hospitals, healthcare facilities, social facilities, related to the historical context, which have not stopped since the last closure of the residential school system and residential school in 1996. These systemic issues contribute to explaining disparities in health outcomes for Indigenous peoples in Canada compared with non-Indigenous peoples. These disparities include in communities chronic disease progression, toxic drug overdoses, disproportionate rates of suicide, infectious disease disparities, racism and discrimination at all points of care. The social determinants of health related to employment, there's a lack of Indigenous specific work-related health supports for issues, a scarcity of resources. Indigenous healthcare systems, as I noticed, are complex and jurisdictional. In surveillance systems, there's a lack of data on First Nations, Inuit, and Métis peoples. There's a failure of public health policies and programs to reflect current Indigenous peoples' lived experiences. In curriculum, we're working on cultural safety and humility and anti-Indigenous specific racism, pedagogies, and practices. So if this is the current state, then what is the way forward? It's important to remind ourselves of the social determinants of health. They are the historical, political, economic, and social conditions under which people live their daily lives and which determine our health. The list of social determinants of health here is from the Public Health Agency of Canada. But really, there is no one list. And in fact, an Indigenous list of social determinants of health will have some of these, but include unique aspects related to being First Nations, Inuit, and Métis in Canada, such as high TB rates, respiratory infections due to lack of adequate and safe housing that leads to overcrowding in Inuit settlements. There's also another factor, a factor of oppression impacting health. That's racism. Racism, as we know, leads to discriminatory behaviors and policies that oppress, ignore, and treat racialized groups as less than non-racialized groups. Racism in society and healthcare can show up in different forms. It can range from individual internalized at the bottom of the picture here as we move up, race beliefs. Then it can progress to between people, biases shown through words, actions, behaviors. At an institutional level, discriminatory policies and practices with organizations and institutions. And at a systemic level, ongoing racial inequalities maintained by society. The types of racisms are occurring now and have roots in our history. You often think, are they historical structures or are they current contemporary structures? We had Indian hospitals where back then we were called Indians and we were segregated into care. We had experiments done without consent on us. Veterinarian doctors often provided services to our people. Children were disabled with spica casts, for those in the medicine and nursing field know what that means. So they're cast down from your hips down to the floor with a bar in between your knees, so you won't be running around the ward and creating chaos. So those Indian hospitals have closed, but structural racism continues today, as evidenced by more recently birth alerts, the in plain sight findings and recommendations as a result of the Price is Right game being played by guessing the blood alcohol levels of Indigenous peoples in the waiting room prior to even being triaged, prior to being spoken to. Birth alerts, which are still active in Quebec, are part of a system where prenatal moms, prenatal records were flagged. And when they came to the hospital, they were met upon delivery of their child with a social worker. The social worker was doing an assessment to take the children into care. And of course, Indigenous peoples were highly disproportionately affected from that system. The In Plain Sight report. I want you to remember the importance of the voices in that report. 185,000 voices contributed to this report. The Indigenous voices said that there's widespread and ongoing stereotyping and racism that leads to discrimination at points of care and negatively affects health outcomes. And of course, if you have that treatment, you're less likely and less apt to access healthcare, aren't you? And inequalities are related to health outcomes. We use a tree metaphor. If you see on the left-hand side, the picture with the two trees, the tree on the left is withered and really shows the results when health inequalities are high and resources are low, leading to negative health outcomes. The next tree shows a vibrant, healthy tree when inequalities are low and community health-based resources are high, leading to positive health outcomes. But the most optimum tree we want is in the next picture, when there's self-determination by nation-based and community-driven healthcare. Then you have positive health outcomes that are sustained and driven by community. And this is really reflected through interconnections, those interconnections of holistic health and the social determinants of health. It is said then that until the social determinants of health and the Public Health Act reflect the lived experiences of Indigenous peoples, the identification of the problem statement in healthcare policies will continue to fall short. of achieving impactful policies that uphold the holistic health and well-being of our people. So with all that, how on earth do we decolonize? What are the steps forward? What do we do? So I'm going to share with you now a few of the things that can be done with community, driven by community, nation-based community approaches, co-development of curriculum, empowering nursing roles. And these are just a few examples, and I'm sure a lot of the academics and my peers in the room have many more. I thought I'd ground us for a moment and reflect and understand of our respective responsibilities. Why do we have to decolonize within the academy, within our professional roles, within the healthcare systems and other social care systems? Because we have standards now as a result of the In Plain Sight report recommendation number 8. I'm going to take a moment and read it out because I think it's important to reflect on. It states that all health policymakers, health authorities, health regulatory bodies, health organizations, health facilities, patient care quality review boards, and health education programs in British Columbia adopt an accreditation standard for achieving Indigenous cultural safety through cultural humility and eliminating Indigenous specific racism. That's been developed in collaboration and cooperation with Indigenous peoples. So with that grounding and reminder, let's move on to some examples. This is an example from an academy perspective, where at TRU, I partnered with the science faculty and the nursing faculty, and we were responding to the In Plain Sight recommendations that affect the academies. We developed workshops over 2 semesters, and we wanted, guided by the elders and led by Tecumseh, which is the local First Nation on which TRU is located. We wanted to help faculty to relearn and unlearn from a Western lens, but to relearn from an Indigenous ways of knowing and being, core curricular concepts, and being intentional to decolonize. We followed the processes that we used in the nursing program because the nurses were ahead of the science faculty. For botany, the elders told stories and taught faculty and students about traditional plants and the interrelationship to the land. For physics, the creation stories and the living ways between lands, water, and sky were taught. Through chemistry and biology, the relationship of plants, animals, water, and atmospheres to each other and to us was discussed. It was really an incredible journey of learning and understanding and unlearning colonial teachings and writing history and the curricular understandings of Indigenous ways of being. We worked to unveil oppression. At the request of the local First Nations Tecumseh, I was asked to develop an interdisciplinary Indigenous health course. To use a decolonizing approach, I followed protocol. I said I'd develop the course with the academy, but we would do it right and take as long as it takes to do it right until the community was satisfied and it was ready. Honoring protocols really means starting with and going to the local Indigenous communities before you start anything. Start with the community in which your college or university is located. They will advise you what to do next. Clarify the protocols for community engagement, what format, who to connect with, which communities first. So we know a lot of academies like UNBC has a lot of satellite universities around, don't we? From different First Nations and community members. So honoring protocol means that courageous conversations need to occur back at the academy when they offer you 3 credits and ask you to do it in 1 semester to develop the course. So that courageous conversation took place because it took 15 months to develop that course with Tecumseh leaders. And again, it was reviewed first by them before it was even brought back to faculty council to start that process, to bring it through curricular review and approval through the Senate. And that course is a requisite course now, and it's been going on for many years. So not only are student evaluations used in review of that course is taken back to the community where the tribal council can review it. Because we know tribal councils change and new people come in. So we wanted to make sure it was current and relevant to become with Secwepemc. Another example is a request that I got from my local First Nations community to develop a course from the Gitxsan First Nations territory. It started with the chiefs that gave the invitation, and then it began from there. I met with key contacts in the Gitxsan territories, because there are many chiefs. Met with respected knowledge keepers and health councils so that they could identify and clarify what do nurses need to know to work with First Nations and Indigenous communities, and in particular, in this case, with Gitxsan people. When I was up in the community developing the course, I sought Gitxsan artists, elders, medicine people, and was intentional to ground the experience in culture, arts, traditions, and ceremonies. And also to be sure that I went up there with the students so I could support and guide them. But in order to support and guide them, I held pre-departure seminars. Those that were committed to going up there spent a semester with me every week, meeting for 3 hours, going through cultural safety and humility, the Gitxsan language, the culture, the practices. And then the end of April, we went into the Gitxsan territory. The students spent 3 weeks in clinical practice, either in trauma centers or in rural regional hospitals, etc., extending all the way from Burns Lake up to Hazelton and Smithers, various sites. Then the next 3 weeks were spent practicing with Gitxsan Nation, with the interdisciplinary healthcare team, with elders, with health professionals, with peer student leaders, with drug and alcohol counselors, with medicine men and women. So in this picture is Roy Henry Vickers, and the students were able to carve out a little bit of a totem pole for UBC's apology pole at that time. And this is the Houston Diagnostic and Treatment Center. And that's Gitxsan Health Society and my nation, Kispiox. So throughout the time, the students practiced cultural safety and humility, but they got feedback from community right away. They got guidance and correction from elders in a respectful manner, and they learned, they grew. This picture, the students are out, we were gathering cedar strips out in the bush with the elders there, and also making button blankets for the TRC bears that uphold Jordan's principle and the TRC's call to action, and making drums as well. And of course, they met more Gitxsan artists, Michelle Stoney, and we have a leader who's teaching totem poles, how to make totem poles to high school students. As a part of reciprocity, the students did presentations to the high school students, talking about nursing and what it meant to them, so that they maybe would think about going into their nursing career. Let's talk about local, the great things UNBC is doing. I've had the pleasure of working with Dr. Vivian Joveski, who's here with us in the room today, Dr. Teresa Healy, and with the local community to look at collaboration, co-developing, co-implementing, and co-evaluating, and determining what are culturally safe practices for the nurses in this area at UNBC. What should we be doing for nursing? Well, here's a little teaser on the background. Well, I'll invite you to come to our session at 1 p.m. in room 6307 this afternoon. And finally, a final example of how to decolonize is through some of the research I'm doing to explore the role of oppression within nursing practice contexts. You can see that incivility is reported and witnessed and experienced at a rate of 77.65% of new Canadian graduated nurses surveyed. Racialized experiences of Canadian nursing students is 45.6%. The top 3 sources are from nurses, faculty, clinical instructors, and student peers. So let's review a few terms before we move on to talk about the organizational context of racialized incivility and incivility experiences. So incivility is really microaggressions, if you will. They're rude, discourteous, disrespectful behaviors that can undermine the organizational culture. Racialized incivility are behaviors that target individuals based on their race, creating hostile and discriminatory work environments. A lot of researchers focus on individual behaviors. My researcher focuses on the organizational culture, the structures, if you will. What are the structures that really create an environment where racialized incivility and incivility are more apt to occur? And what I found through my master's degree and a few other research projects and my doctoral studies is really we should start at the beginning of a negative workplace environment continuum with the workplace structures and incivility and racialized incivility before it escalates to workplace bullying and workplace violence. And there's a potential here, not only between individuals to experience these types of behaviors and treatments, there's a potential to spiral off to other nodes where it can lead to groups and mobbing behaviors. So again, looking at the origin of incivility. And you may be thinking to yourself, well, what is the origin of oppression in nursing and how on earth did that happen? And how is it sustained? This is Prince George Hospital back in 1919. When nursing started in British Columbia, it was situated under healthcare professionals. And at that time, nurses were schooled under the physicians and under the care of physicians and guidance. So since that time, hospitals have really modernized their technology, their equipment, and they've really advanced. But still, ironically, nurses are finding that they know the right thing to do to change the healthcare environment, but they don't have the power within their roles, the formal authority to impact them. And this is what's happening. Nurses and new graduate nurses are leading the profession from being overwhelmed, stressed, and those that are staying fear for the well-being of their patients. They're running on empty. So research findings have demonstrated that if we look at structural empowerment, that this shows promise to mitigate job stressors and ultimately racialized incivility and incivility experiences of new graduate nurses. So we look at the role of empowerment along that continuum to mitigate those experiences. And today, research is happening between the First Nations Health Authority and the Northern Health Authority, who are serious about addressing this issue and to change. And for this, we're using a theoretical model of intersectionality and ecology, based in part on my doctoral studies to look at the role of structural empowerment and how to mitigate those behaviors. It's a two-phase approach, a pilot study, a survey, excuse me, using quantitative and qualitative data. And so really, these impacts really will look at illuminating those organizational precursors or antecedents that are leading to these behaviors. It'll look at defining and refining the problem statement in policies as it relates to anti-incivility and anti-racial policies. But importantly, it's going to improve the nursing practice environment. For those new graduate nurses who are working in the field, and also lead to retention and recruitment of students who see a change in that environment. So how do we find a way forward? When I thought about this presentation and I was thinking about, wow, it's a heavy topic, isn't it? Decolonizing health, dismantling oppression. I thought about the motto of UNBC. Now reflect on that vision for a moment. In Chahuna, All people have a voice and a viewpoint. So this directly translates to he, she also lives, and is interpreted as respecting all forms of life. So this work is done together. We're doing this work together. It's in partnership with communities and our allies, local First Nations, Métis, and Inuit peoples to develop curriculum and deliver it, to identify nation-based, community-driven research topics to work in partnership, and research and scholarship to improve nursing practice environments through mitigating those sources of incivility and structural change. And evolving healthcare acts and legislation to improve healthcare delivery and experiences at all points of care. Enchahuna. And with that, I'd like to say, Lucy Cho, Hamaya. Thank you so much.
Thank you so much, Dr. Blackstock. At this time, we'd like to invite questions, online or in person. Marcella and I will be, we have a mic and we'll read the questions off online.
I can help out.
Merci, thank you so much, Sheila. That was, I particularly resonated with the way you wove things together and ended on this Inshahana challenge for us all. Thank you for that. My question is imagining the whole workforce infused by these kinds of ideas, and that tricky challenge of what we can do for the people that are still being trained versus what we might need to do for the people that have already been trained in that sort of professional development space. And although this is already a big vision and plenty to do, I just wonder if you could comment at all about innovations that you could imagine thriving with people that are already in practice. Thanks.
Yeah, thank you so much for that question. And respectfully, I'll invite you to come to the 1 o'clock session this afternoon. A little teaser there, but yeah, great work is being done with community members. And importantly, it, as you say, it's not just about students. What about the people who are currently in the system and continuing education and what needs to be done there? And I think from the research is showing that really people need to be held accountable through annual workplace performance reviews tied to annual regulation. And I'm speaking right now with a nursing hat on. And I think similar cases could be made for other regulatory bodies and healthcare professionals, social professionals as well. So really important to do this work with community and not to take anyone else's work and just use it as a cookie cutter approach to curriculum within the academies. You have to make those connections with the local First Nations, Métis and Inuit peoples and communities to be authentic, to be relevant, to be meaningful, and to sustain course changes, because otherwise you will not make a change, a meaningful change. Thank you.